Imagine you have this deflated, really wrinkled rubber balloon.
Okay, I'm picturing it.
It's totally floppy, right? It's completely lost its shape, and the rubber is sort of just folded over itself. Now imagine I hand you a needle and tell you to inject a precise drop of fluid directly into the microscopic middle layer of that floppy rubber.
Oh, wow.
Yeah, but get this. You have to do it without poking all the way through to the other side and without injecting too shallow either.
I mean, that is just a terrifying physics problem, honestly.
Right. It seems impossible.
But that exact structural challenge is what clinicians face every single day.
Mm.
When they're targeting the submucosa in human tissues that are hyper-lax, meaning severely loose or just structurally distorted.
You're trying to find a microscopic gap in an environment that literally refuses to hold still.
Exactly. The submucosa is really the critical battleground here. It's the layer sitting just beneath the surface lining, which is the mucosa, but right above the much thicker, deeper muscle layers.
So it's sandwiched right in the middle.
Right in the middle. And accessing it safely gives surgeons a pathway to perform some incredibly advanced procedures. But the margin for error isn't just small. It's practically invisible.
So today's mission on this deep dive is to figure out exactly how medical professionals verify that their needle is in that microscopic sweet spot.
It's a fascinating process.
We're looking at situations like repairing a prolapsed anterior vaginal wall or maybe removing a precancerous lesion from a shifting stomach lining. Like, how do you navigate a space you can barely even see?
It takes a lot of ingenuity, that's for sure.
To understand the mechanics of this, we're synthesizing a whole stack of sources for you today. We've got surgical technique manuals, gastroenterology studies on stomach and rectal lesions, and some cutting-edge urological research.
And we're going to uncover the tactile, the chemical, and the sonic methods surgeons use to actually hit their marks.
Because when you really look at the source material, this isn't just biology anymore.
No, not at all.
It is fluid dynamics, chemistry, and acoustic engineering all rolled into one.
Yeah, the cross-disciplinary nature of this is really what stands out. Because whether you're a urologist, a gynecologist, or a gastroenterologist, you're ultimately trying to solve the exact same mechanical puzzle.
Which is confidently injecting fluid into a space to separate tissue layers without, causing a catastrophic tear.
Exactly. So how do you actually execute this balloon injection physics problem in a human body?
Let's look at pelvic organ prolapse first. Specifically, repairing the anterior vaginal wall, because the structural integrity of the tissue here has basically completely failed.
Right. So in a prolapse, the tissue is hyper-lax. It's lost its normal tension, its elasticity. The surgeon needs to enter what the surgical texts call the vesicovaginal space.
That's the specific plane between the bladder and the vagina, right?
Yes. But here's the catch. This isn't an open cavern. It's what they call a potential space.
Which means under normal conditions, there is no actual space there at all.
None.
It's like a plastic sandwich bag that's been completely flattened out. The two sides are just touching.
Exactly. There's minimal fat, and the layers are practically fused together. So to safely separate them, the surgeon relies on a very specific tool to create the entry point. They use an 18-gauge Tuohy needle.
And a Tuohy needle isn't designed like a standard syringe you'd see at, like, a regular doctor's office, right?
No, not at all. It doesn't have a perfectly sharp slanted bubble. It has a slightly rounded, curved tip.
Oh, interesting.
And that geometry is totally intentional, because if you use a razor-sharp needle, it's just going to slice smoothly through every layer.
Including the ones you really want to avoid.
Precisely. The blunt, curved tip of the Tuohy needle actually forces the tissue to resist.
Okay, so as the surgeon pushes this needle through the vaginal wall, which, by the way, is usually only about 5 to 7 millimeters deep, they're constantly watching these 5-millimeter colored segments painted on the needle shaft.
Right, for a visual depth reference. But watching the paint on the needle is really only half the strategy.
Yeah, the ultimate verification of depths here isn't visual at all. It's tactile. The sources detail this very distinct popping sensation.
Yeah, that pop is crucial. Because of that rounded tip we talked about, the needle pushes against the dense fibrous tissue of the vaginal wall, and it builds up mechanical resistance.
So the surgeon is applying steady, continuous pressure.
Right. And when the tip finally breaches the full thickness of that wall and enters the empty, frictionless vesicovaginal space, the physical resistance just instantly vanishes.
Wow.
That sudden drop in tension translates straight up the needle into the surgeon's hand as a definitive pop.
But I mean, if you're relying purely on feeling a physical pop in tissue that is already floppy and distorted,
Hmm.
the margin for error must be incredibly razor thin.
Oh, it is.
So what actually happens mechanically if they push just a millimeter too far, or maybe stop a millimeter too short?
Well, the anatomy is entirely unforgiving here. If the injection is too shallow, meaning the fluid goes into the surface mucosal layer or the thin muscularis mucosae, the fluid has nowhere to expand.
Because that surface layer doesn't stretch, right?
It doesn't stretch at all. So the mechanical pressure of the fluid physically rips the tiny, delicate blood vessels in that shallow layer.
Oh, that sounds bad.
It is. This instantly creates a superficial hematoma, which is basically a massive blood blister. For a surgeon, this is a worst-case scenario.
Because it completely obscures the visual field.
Exactly. It obscures vision, it bleeds continuously, and it makes finding the safe cutting plane nearly impossible.
You know, it reminds me of trying to cut a tomato with a dull knife, and you just watch the skin sort of mash and slide around.
That's a really good analogy, yeah.
You can imagine the sheer anxiety of trying to operate on a tissue plane that has turned into a bleeding blister. So what is the mechanical consequence of going too deep?
So if the needle bypasses the submucosa entirely, the fluid injects into the subserous layer. Or, in abdominal procedures, it spills out intraperitoneally.
Meaning the fluid just vanishes into the abdominal cavity?
Yes, it's just gone. And the structural result is zero mucosal lift. The layers don't separate at all.
And if the surgeon fails to recognize that the tissue hasn't lifted, and they decide to make an incision anyway,
Then their scalpel or electrosurgical blade is sitting directly on top of the deep muscle layer. Slicing into that muscle can cause a full-thickness perforation of the organ.
which is a disaster. So finding that exact middle layer is the literal difference between a routine separation and a massive surgical complication.
Absolutely.
So once they feel that pop, they don't just start cutting, right? They have to prove they're in the right spot visually first.
Correct. They perform hydrodissection. So they inject a 20 milliliter pocket of fluid right into that potential space. Specifically, the sources mention a cocktail of 0.25% marcaine with epinephrine, diluted 1-to-1 with injectable saline.
And the epinephrine is key there, right? Because it constricts local blood vessels, keeping the area clear of blood.
Exactly. So when they finally make the incision into that fluid pocket, the visual verification is highly specific. They are looking for what the literature describes as a silver-gray, jelly-like space containing yellow wisps of fat.
Silver gray jelly.
Yeah. If they see that, they know the space is successfully separated and completely safe to navigate.
That's incredible. And we actually see this exact same mechanical principle applied in the GI tract, just with a different visual cue, like in an endoscopic submucosal dissection or ESD, when surgeons remove precancerous tumors from the stomach lining.
Right.
But I mean, the stomach is constantly churning and shifting. How do you find the submucosa in there?
So in the stomach, they use a dynamic injection technique. The surgeon deliberately inserts the needle just a little bit too deeply and then pulls it back very, very gradually while simultaneously pumping fluid through the syringe.
So they're injecting as they withdraw.
Right. They keep pulling back millimeter by millimeter until they see the surface mucosa suddenly rise up into a distinct dome. The literature actually affectionately calls it a bluish fish bladder bubble.
A fish bladder bubble. I love how specific these medical terms get.
I know, right? But when that high-tension bubble forms, it proves the fluid is trapped perfectly in the submucosal plane. It lifts the dangerous lesion up and away from the muscle layer.
But this brings up a massive logistical problem. Let's say you get the perfect pop and you form the perfect fish bladder bubble. These surgeries take a long time. If you just inject standard normal saline, the body's capillary network is going to absorb that salt water almost immediately, right?
Yeah, you've isolated the core limitation of mechanical verification right there.
Yes.
Standard saline dissipates far too rapidly.
So the bubble just deflates.
Exactly. The submucosal cushion simply flattens out, the tissue collapses back down, and the surgeon is suddenly flying blind again, dangerously close to the muscle.
Think of it like trying to fill a water balloon with standard tap water versus filling it with like a really thick hair gel.
Oh, that's a perfect way to picture it.
Right. If you poke a tiny hole in the water balloon, the tap water shoots out and it deflates instantly. But the gel is dense enough to hold its shape even if the barrier is compromised.
And that physical property is exactly why clinicians have to engineer the injection fluid itself. They're moving from mechanical verification to chemical verification. And they are severely limited in what they can actually use. Like, they can't just inject pure, sterile water to create the lift.
Wait, why not? Water is cheap, it's accessible.
Because modern procedures rely heavily on electrosurgery. Surgeons use high-frequency electrical current to simultaneously cut tissue and cauterize blood vessels.
Oh, okay.
Pure water does not conduct electricity. So if you create a barrier of pure water, the electrosurgical knife just won't function properly. The fluid must contain ions. It has to be conductive.
So they need a fluid that conducts electricity but is chemically dense enough to resist being absorbed by the body. What exactly are they mixing up then?
Well, the sources outline this fascinating pharmacy of hyperosmolar and viscous solutions. For instance, they use a 20% mannitol mixture.
And hyperosmolar essentially means the fluid is so dense with molecules like the mannitol that it physically alters the osmotic pressure, right? So instead of the body absorbing the fluid, the mannitol actually draws surrounding water from the body into the bubble, keeping it inflated for much longer.
Precisely. They also rely on sodium hyaluronate.
Mm.
We usually associate hyaluronic acid with, holding moisture in skincare, dermatology. But here it is weaponized for its extreme viscosity.
It creates a super thick, resilient cushion.
It really does. And the literature even details the use of reverse-phase polymers.
Okay, I have to ask, how do reverse-phase polymers work in this context?
Oh, they are brilliant pieces of chemical engineering.
Mm-hmm.
Reverse-phase polymer is a liquid at room temperature, which means it easily flows right through a microscopic needle.
Nice and easy.
But the moment it enters the human body and hits 98.6 degrees Fahrenheit, that temperature change causes the molecular structure to shift. It instantly turns into a rigid gel, essentially locking the submucosal space open.
That is wild. And earlier you mentioned a bluish fish bladder bubble. Where does the color actually come from? Ah, they mix in a dye called 4% indigo carmine. The blue dye physically stains the submucosal fibers. This gives the surgeon a high-contrast visual map. The safe submucosal tissue is bright blue, and the dangerous deep muscle layer remains its natural pink.
So you know exactly what you're looking at. There's also a detail in the sources about the physical strategy of the injection itself that completely changes how you picture the procedure. Like, they don't just stab the needle directly underneath the tumor they want to cut out.
No, you definitely don't want to do that. If you inject directly under the lesion, the moment you make your first incision, you puncture the highest pressure point of the bubble.
And then it pops.
Yeah, the fluid immediately leaks out, and you lose your lift entirely.
So it's basically a geometry problem. The rule is to inject exactly 1 centimeter away from the lesion. By doing that, the fluid spreads out underneath the tissue like a wave, creating the highest peak of elevation exactly 0.5 centimeters away from the target.
Which provides the safest possible entry point to start the cut. It is literally microscopic billiards, calculating exactly how viscous fluid will disperse through cellular tissue.
It really is. And if we look at the extreme end of fluid dynamics in surgery, some tools have actually eliminated the metal needle entirely.
Oh, you mean the high-pressure knife injectors, tools like the hybrid knife or the Nestasenki II.
Exactly. Instead of relying on a physical needle to feel for a pop, these instruments use a highly calibrated, hair-thin jet of pressurized water.
Just a jet of water.
Just water. The kinetic energy of the jet is tuned to punch straight through the tough, fibrous mucosa. But once it hits the softer, looser submucosa, the pressure instantly disperses outward. The water jet essentially hydrodissects its own path, filling the space automatically.
That's amazing. But, I mean, let's be real. Even with reverse-phase polymers, blue dye, and pressurized water jets, there has to be a limit.
There always is.
What happens when the patient's anatomy is so severely damaged, say, a thick fibrotic tumor or a bladder heavily scarred from a previous surgery, that the tissue is basically glued together? The tissue won't pop, the water won't spread, and a bubble definitely won't form.
You're absolutely right. When scar tissue obliterates the anatomical planes, tactile and visual cues completely fail. If you try to force fluid into fibrotic tissue, it won't separate. It'll just tear.
So what do they do?
When clinicians can't feel it and they can't see it, they have to transition to active sonic tracking.
They use ultrasound to map the layers.
Exactly. Let's look at vesicoretral reflux, or VUR, which is detailed in the urology sources. This is a condition where the valve between the bladder and the kidneys fails, allowing urine to flow backward.
Not good.
No. To repair it, surgeons inject a very thick bulking agent, a paste called dextranomer hyaluronic acid, or DXHA, into the submucosa of the ureteral opening.
And the goal there is to build a physical mound of this paste inside the wall to act as a sort of one-way valve. But if the bladder wall is structurally altered by disease, finding that layer blindly is incredibly dangerous.
Super dangerous. So they use dual operator guidance. While a primary surgeon is operating the needle through the cystoscope, a second surgeon performs a continuous ultrasound.
So they have an extra set of eyes, basically.
Right, but better than eyes. The high-frequency sound waves allow them to look right through the opaque tissue. It verifies the needle is in the exact submucosal plane. It ensures the needle stays perfectly centered during the injection, and it lets them visually track the volume of the DXHA mound as it builds.
So they can stop the exact second it reaches the necessary height. We actually see this same sonic mapping used for rectal lesions too, don't we? The anatomy down there is incredibly tight.
Yeah. Very tight. In the rectum, the submucosa and the muscularis propria are pressed hard against each other. If a surgeon is trying to remove a subepithelial lesion, which is a tumor buried deep beneath the surface, they have to prove it isn't attached to the deep muscle layer.
Because if you try to cut out a tumor that's attached to the muscle, you'll just punch a hole straight through the rectal wall.
Exactly.
So how do they actually prove separation before they cut?
They take a microscopic 25-gauge needle and inject saline circumferentially around the base of the lesion. Then they deploy endoscopic ultrasonography, or EUS. They place an ultrasound probe directly inside the rectum.
Okay, so they're right up against it.
Right. The sound waves bounce back and generate an image. The surgeon is looking for a dark band of fluid on the monitor. If that dark fluid layer completely separates the white mass of the tumor from the deeper muscle wall, it proves the lesion is isolated to the submucosa.
And only then is it safe to cut. But here is where we run into a major limitation of ultrasound, and it's something anyone who has tried to reflect light off a surface has probably experienced. It's a phenomenon called specular reflection.
Specular reflection is a massive vulnerability in standard ultrasound guidance.
Think of it like shining a flashlight at a mirror in a really dark room.
Okay, sure.
If you stand directly in front of the mirror and shine the light straight at it like a perfect 90-degree angle, the light bounces straight back into your eyes and you can see the mirror clearly. But if you stand way off to the side and shine the flashlight at a sharp, steep angle, the light bounces off the mirror and hits the far corner of the room.
Right, the mirror just looks dark.
Exactly, the mirror just looks dark. And the exact same physics apply to sound waves hitting a metal needle.
That is the perfect way to understand it. The ultrasound probe is the flashlight, and the metal needle is the mirror. If the surgeon inserts the needle at a steep angle, the sound waves bounce away into the surrounding tissue instead of returning to the probe.
So the needle just practically vanishes from the monitor.
It really does. You're left with a dangerous blind spot right when you need precision the most.
And this brings us to the absolute cutting edge of the source material. Like, how do you solve the flashlight and mirror problem? You make the mirror generate its own light.
Yes.
The ultimate verification tool we found relies on a miniature fiber optic ultrasound hydrophone.
The level of engineering here is just astounding.
So they integrate this microscopic hydrophone directly into the tip of a 20-gauge injection needle. So instead of just bouncing sound waves off the metal from the outside, the needle itself is actively listening to the ultrasound pulses.
Exactly. The needle is no longer a passive object. The fiber optic sensor inside the tip receives the acoustic pressure waves coming from the external ultrasound probe.
Wow.
When the sound waves hit the sensor, they physically compress it, which changes the optical light signal traveling through the fiber inside the needle. That light signal is sent back to a computer, which translates it into exact coordinates.
So the needle is essentially shouting, "I am exactly right here," directly to the computer.
That's exactly what it's doing. It allows for continuous sub-millimeter tracking of the needle tip, even at incredibly steep insertion angles. The clinical data shows this technology working flawlessly up to a 68-degree angle.
That's huge.
By turning the needle into an active receiver, it completely eliminates the blind spot of specular reflection. The surgeon never has to guess where the tip is, because the tip is actively mapping its own location in three-dimensional space.
It fundamentally rewrites the safety paradigm for operating in distorted tissues. The fact that we can manufacture a fiber optic hydrophone small enough to fit inside a needle that is a fraction of a millimeter wide, it really puts the complexity of modern medicine into perspective.
It's mind-blowing.
Let's take a breath and recap the journey we've taken through these sources. We started with the sheer physical challenge of navigating hyper-lax, floppy tissues. We saw how finding a space that doesn't natively exist relies on the highly trained physical sensation of a surgeon, the tactile pod of a blunt-tipped 2-OHE needle finally breaching the resistance of the vaginal wall.
Right. And then we explored how surgeons have to alter the very chemistry of the surgical environment. Because standard saline absorbs too quickly, they rely on hyperosmolar forces, extreme viscosity from sodium hyaluronate, and reverse-phase polymers to maintain that critical fish bladder bubble.
And finally, we arrived at the sonic frontier. When scar tissue and fibrosis destroy tactile and visual cues, clinicians use sound waves to look right through the tissue, utilizing fiber optic hydrophones that listen to ultrasound pulses to navigate with sub-millimeter accuracy.
It drives home a core truth for me. Surgical mastery today isn't just about understanding anatomy. It is a deep, real-time synthesis of anatomical structure, chemical fluid dynamics, and acoustic physics.
It is all interconnected. Which brings me to a final thought I want you to consider today. We just discussed integrating a fiber optic hydrophone inside a microscopic needle so it can track its own position using external sound waves.
Right.
If we have that technology functioning today, how far away are we from true smart needles?
Oh, that's an interesting thought.
Imagine a needle equipped with sensors that don't just listen for location, but actually autonomously measure the microscopic cellular density of the tissue they're sliding through. A needle that knows the exact microsecond it enters the loose submucosa and automatically deploys the perfect volume of reverse-phase polymer fluid instantly.
It would completely remove human reaction time and the need for a tactile pop from the equation entirely.
Exactly. Moving from instruments that merely assist a surgeon's senses to autonomous instruments that possess senses of their own.
It is the logical and honestly incredibly fascinating next step.
Something to ponder the next time you think about the hidden mechanics of modern medicine. Thank you for taking this deep dive with us. Remember to stay curious, keep questioning how things actually work, and we will see you next time.